Thank you. Wow. So it's always on my bucket list to get applause, so I guess I'm there. So I'm really, really excited to be here, and I'm very happy to see everybody attending this afternoon. And just to give you a quick introduction, I am a family nurse practitioner who about 15 years ago took a left turn into the dark side of IT, and where they drink Red Bull and eat Snickers bars 99% of the time. So, and if you do that, if you throw that under the door, it keeps them happy too. But at any rate, what I've done with the last 9 years of my life of my career is I've been consulting with groups across the country around electronic medical record in terms of operational optimization, optimization of the product itself, as well as worked on a number of system selection projects, implementation projects, just sort of everything that has anything to do with IT. And this, over the last year, I've really been focused on how do I really strongly couple my understanding of the clinical workings of a health center and an electronic medical record, and how you really create the kind of synergy around those two things that you can. So I have been a clinic manager. I have practiced in a clinic. I have actually implemented the electronic medical record where I worked, as well as used an electronic medical record as a provider. So that's the experience that I bring to this. And so what we're going to talk about today is how we can use patient-centered medical home not as an end, which I know you all know that it isn't an end, although when you get that application done, you do take a big sigh of relief, and when you get your designation back, you take a bigger sigh of relief. So it feels like an end, but it's really a springboard to transformation. And quite frankly, that's what meaningful use was all about as well, or is all about. It's about how do we create some kind of incentive and standard to ask providers to be doing what we need them to do anyway. But when we were able to wrap it in meaningful use and put some incentive with it, it made my job a wee bit easier, because initially I was just sort of strong-arming a lot of the work that needed to be done. So we're going to try to list out some of the components that are addressed by high-performing practices, and I'm really focused on what makes a practice high-performing and how you might be able to set your sights on being high-performing if you're not there already, or how you can continuously stay there. Talk about how the EHR can be employed to support the transformation of a practice and you be the master of it instead of it being the master of you, which I'm sure many of you feel. And then talk about how you can design some, short cycle quality improvement projects that will lead to practice transformation. So before I get started completely, I'd like to understand a little bit more of where you all are coming from. So how many of you are in the middle of patient-centered medical home applications? How many of you have the designation? Level 3, 1, 3? Corporate? Or just, are you single center? Single center, okay. Anybody else working on it? Thinking about working on it? Okay. How many of you have electronic medical records that you're trying to wrangle? Okay. How many of you are happy with your electronic medical records? Wow. What are you using? That's why. That explains a lot. Anybody else? Happy? What do you? Okay. Okay. Yeah. Yes, it is. Yes, it is. Okay. Yeah. Maybe we should employ them in that. So, okay, good. So I do invite you to stop me and ask questions as we go. Your questions are probably more important than my slides, okay? So I'm hoping that my slides actually stimulate some discussion rather than me just standing up here talking at you. So I'm going to start with a framework that you probably have seen many, many, many times before. I've just deconstructed it a little bit. So we're talking about what is this medical home framework. So the beginning, it starts with being patient-centered. Now, I've been a nurse since the earth cooled, okay? We have been talking about patient-centered care since the earth cooled. And we're still talking about patient-centered care. And it seems like on some level it ought to be a no-brainer, right? Because after all, without the patients, we really wouldn't have anything to do. So why isn't this patient-centered is my question. What's stopping us from making it patient-centered? So what the framework is really talking about is a methodology that really supports patients and families to manage and organize their own care, and they're fully informed partners in this health system transformation at the practice and community and policy levels. So not just, you know, that they're an active participant in this process. So what does that mean in terms of strategy? Well, it might mean something like having dedicated staff people who really help patients navigate. It might mean a focus on strong, trusting relationships. And I'm going to talk more about that. And I don't mean just strong, trusting relationships between the patient and the provider, but also between and among your team. I was with a group last week, and we were running through a workshop talking a lot about how do we get team-based care in place, and how do we improve the way that care is delivered in our health centers. And we were talking about medical assistants, and I might be already striking a nerve here, medical assistants doing med reconciliation, right? We expect our patients to do med reconciliation. We expect our patients to know everything about their medications. And she was very frustrated and angry with me about bringing this up. And after a while, she finally said, I don't trust them. Now, that was a big admission, and I give her a ton of credit for getting to that place to really verbalize it. But until we fix that trust relationship, the rest of it can't come. The rest of it won't happen. And we won't have patient-centered care if we're not in a team situation where we're really trusting the people that we're working with. So I just throw that out there. And then, of course, compassionate and culturally sensitive care. I mean, really understanding that we don't want to be blaming the victim here as a patient. The next step in this framework is have it be comprehensive. We've been talking about holistic care since the earth cooled, and we're still talking about holistic care. I've often said that, you know, what I'm really looking for, you know, is not that place where if you could just drop your heart off, we'll service it for you, and you can pick it up this afternoon. So I mean, I think that we're perfectly comfortable dealing with the disease process, but not so much the person who has the disease process. And how do we really fix that part of it? So it really means that we have a team of providers who are wholly accountable for the patient's physical and mental health. Now, I think this is where we all get a little bit worried. That we're accountable. Didn't it say in the previous slide that the patient was supposed to be an active participant in this whole process? So now we're saying that the team of care providers is wholly accountable. And I think we really need to be thinking about what does that look like? Does it look like me standing beside you, helping you to be as accountable for your own self as you can be? Or does it really mean that I'm always filling in the blanks? That I'm the one chasing you to get your colonoscopy, that I'm the one chasing you to get your mammogram, that I'm the one making the appointment so that you get to the specialist. I just think we need to be thinking about it. And what is our role, and how can we use the information that we have to inform that whole process. So, you know, some of the strategies are focus on a whole person and population health. I know that that's an area that all of you are in the thick of. With patient-centered medical home, your EMRs, maybe with the exception of Epic, may or may not be supporting that work of doing true population management, and sometimes those systems need to be augmented by other systems or other ways of thinking about them to really get to the population health that you're looking to get to. And co-locating primary care with behavioral health, mental health services, with oral health services, with OBGYN, which most of us see as primary care for women anyway. But thinking about that sort of one-stop shopping that can happen when we co-locate all those services. And then, of course, with a special attention on chronic disease and management of complex health problems. Because the older that we get and the longer that we live, the more, obviously, chronic disease that we're going to be dealing with. So then the next part of this framework is coordination. And this is to ensure that care is organized across all elements of the broader healthcare system. How many of you struggle to get reports from the local hospital system so that you know what's going on with your patients? How many of you get a little frustrated because the patient was in the emergency room and didn't have all of the information that was needed to adequately or efficiently or effectively take care of them, or that you didn't know they were there? So this goes well beyond many of the walls of our health centers, because we need the cooperation of the larger systems around us. And at least in my part of the world, I live in Philadelphia, so in southeast Pennsylvania, we're still working through that. We have 5 medical schools in the city of Philadelphia. We have many, many health systems in the surrounding area, and we are still working through how do we make sure that patients, that the providers, people taking care of these patients, know everything that's happened with them and can effectively and efficiently take care of them. So care is documented and communicated across providers and institutions. And again, how do you get the patient to be engaged in that? And how do you get patients to understand that their path will get smoother if they take some of the workload of that, and how can we make it easier for them? So for example, patient portals, and how are we using patient portals? And how are we using continuous care documents, CCD documents? How are we using our systems to automatically push those out and automatically receive those in, so that these become more habit and less things that we have to think about each time that we're taking care of a patient? The next one is accessibility, so that we deliver consumer-friendly services with shorter wait times, extended hours, 24/7, electronic or telephone access, and strong communication through health IT innovation. So one of the areas I think that we may want to discuss, and we have somewhat struggled with, is this whole idea of asynchronous communication through secure messaging or email with providers. How many of you have that up and running in any of your sites or using any kind of secure messaging? You are. Is it working? Yeah. So are you using it? Yeah. But often, so when you're often the difficulty around secure messaging is that providers think, how am I going to do that? I'm being bombarded by phone calls, and now you're going to bombard me with email. How am I going to keep up with all of this? And what I'm here to tell you is that when you put something like that in place, you can often reduce the amount of phone calls significantly. And the communication's more effective because the patient can read it. Their kid can read it if they choose to. Their grandchild can read it if they choose to let them. They can go back to it and read it again, so that there's better understanding often, and there's fewer follow-up questions that happen when you're communicating in that way. The other focus, and maybe not so much in this group, but in others, is that we don't get paid for this communication. We don't get reimbursed for providing this level of care. We can't charge for an e-visit yet, although some insurers, limited, are allowing you to bill for that. But I would suggest that we look at this not as a non-revenue generating event, but rather a cost savings event, because it really does ultimately change the cost of you delivering care, allowing your providers to be in an asynchronous and not having to stop what they're doing, do something else, start up again, stop again, start again. That is very, very, very disruptive, and it really eats into productive time. So And I think the other area that's somewhat untapped is telemedicine, and how could we be using more telehealth, even home-based telehealth, to improve access and decrease the burden on the health center or the provider. So then we have committed to quality and safety, and this, you know, again, through the use of health IT and other tools to ensure that families can make informed decisions. And this is all about how do we get some embedded clinical decision support at the level of the point of care, and really be helping providers know, you know, you missed that, or this patient hasn't had an A1C in 90 days. Would you like to order it now? And making that path to really implementing standards very, very easy, very, very automated in many ways. And we're going to talk about some other methods that aren't quite so high tech as well today, about how we can do that. Okay, so what are some of the impacts that we might see from employing this framework? We might see that the patient is more likely to seek the right kind of care at the right time, less likely to use an emergency room when they could use their provider, because you are doing a lot to enhance that trust relationship. You're improving access. You're giving people more opportunity to use you rather than the emergency room. They're also, providers are less likely to order duplicate tests because we have all of the information in front of us at the right time. I call it just enough, just in time. So anytime we're thinking about how to employ IT, we need to be thinking about who needs to see the information, when do they need to see the information, and how do they need to see the information. So we get just enough information in front of just the right person at just the right time. And if we focus on that, the rest sort of follows. It gives us the opportunity to better manage chronic diseases. And again, I guess I get a little bit, I rail about this a little bit, because it's not up to us to manage the chronic disease, but to empower the patient to manage their chronic disease. It's not my chronic disease, it's the patient's situation. And we want to give them the tools that they need to be able to manage it. And then a focus on wellness and prevention to reduce the severity of illness, and ultimately, it says so here in the fine print, that we have a cost savings as a result of all of that. So that's the Holy Grail, right? That's the ideal. That's what we're looking for. So now let's get down into the messy world of actually delivering care, because it is messy. It isn't perfect. We can't orchestrate it all the time. Things happen that we have to respond and react to. So how do we get there? But that's the way the Holy Grail looks when we put it all together. Such nice, neat little boxes that just flow up and down and left to right. But you know, the reality is it's a step forward and a half step back. And so how do we get to the high-performing practices? Well, the first step is engaged leadership. And I know that seems very basic, and of course we need engaged leadership, right? But I really think that we need to think as leaders, you know, what does that mean to be engaged? And I would really encourage you to be thinking a little bit more about being the guide on the side and not the sage on the stage. So more of a coach, more of a giving your people the tools to be successful rather than always giving them solutions. And I struggle with this a lot because I'm a consultant, right? I consult. People come to me for answers. But the reality is the more questions I ask, the better my clients do, because they often have the solutions. The problem is that they can't see them. So what I'm really more looking for is the opportunity to uncover the solutions, because they're all there. It's just a matter of being able to see them. And sometimes it just takes a different perspective. So the next area is being data-driven, and we can't be data-driven unless we have working electronic medical records. And many of the groups I work with are struggling to get reporting out of their electronic medical records. And the reason that they're struggling is because the structure of most electronic medical records is such that you really need to understand how the data is going in order to get it out. But you need to know that before you build it. You need to know the data that you want out of it before you start. And most groups didn't start there. And then the other thing is the electronic medical record vendors tell you, you can use it this way, you can use it that way. You can enter the data from this screen, or you can enter the data from that screen. And what they don't tell you is, if you don't all enter it from the same place, or at least know where everybody's entering it from, you're not going to be able to get the data out. So understanding that structure from the get is extremely important. And often just fixing that part helps a great deal. Impanelment, we're going to talk about that in a little bit more. Team-based care, we're going to talk about that a lot. And then the patient-team partnership, again, population management, continuity of care, prompt access to care, the coordination of the care, and this ultimately leads to a transformation from more of a provider-centric model to more of a patient-focused model. So hopefully I'll make that point by the time I finish up today. Okay, so motivating the primary care team and fostering autonomy. The fewer times that the staff has to come to the CEO to ask, the better off you are. And if they're coming to you to engage you in talking through solutions, then you're probably there. If they're always coming to you asking for solutions, then that might be a red flag to be working a little bit more on autonomy. Encourage mastery. Many of you if you have kids, you're doing this all the time. You're encouraging mastery. So we want to get our teams to be as well skilled as possible. And then, use goals and problem statements to clarify the purpose. In other words, constantly ask them questions and see if you can get folks to clarify on their own. This is an area where I've had a fair amount of success is, we tend to ask all the time, what's the return on investment? What am I going to get from that? And I really strongly urge you to get focused on your objective rather than what your return on your investment is going to be. So what's the return on objective? How do we stay focused on the objective? Because quite frankly, the return on investment will follow if we stay focused on objective. And objective is a much it's a much broader way of thinking about it. It will get you more bang for your buck, and it will probably get you to really think about the things that you need to be thinking about, and not just so focused on what does this cost, but rather what's the value. So, data-driven improvement. I recommend designing a data improvement team that includes at least all of these layers of the organization. In my experience, IT is way too late to the table. We bring IT in when we've already decided what we're going to do, instead of bringing them in when we're germinating the idea, so that they can give us ideas about how we could be using IT to better do what we're trying to do. And often, they're just brought in and they're told, well, we want you to do, I'm trying to think of a good example. So we want access to the electronic medical record for everybody who rooms a patient, everybody's in the room with a patient. So that means hardwiring, PCs in every room, maybe. But now we don't have access to electronic medical record when we're out in the hall. Or we've got to get 2 machines for everybody who's in our organization, because we need a machine that's in the room, and then we need a machine that's outside of the room. So instead of saying, this is what we want to do, what are our options, getting IT to the table early is really important, and getting these folks to be talking to each other. Worked with a group recently where we spent our focus. I did an IT improvement project for them, an IT optimization project, and our focus was dashboards. So what that meant was that all roads led to dashboards. So what that meant for us is we had to be getting data out of the system in a way that was meaningful to the provider. And we didn't have any reporting tools, and we didn't have anybody on staff who could do crystal reports. So how do we do this? So we ultimately developed. They did have a database administrator. I sat with him. I helped him understand all the components of the reporting. We sat together and figured out where it was coming out of the system. We looked at what we had, and we were able to give feedback to every provider as to how they could improve that by using a more standardized approach to the electronic medical record. And ultimately, I think we taught every NP in the group how to do a pivot table in Excel, how to sort Excel, how to filter Excel, so that they could do more meaningful stuff with minimal tools, basic tools. Then create a form and process for data validation. That was the other big thing. It's like, well, this can't be. I know I do a better job of immunizing babies. This can't be me. Well, it turned out that we were putting data in all the wrong places. It wasn't attached to the right terms to be able to pull it out, and that's how we were able to fix that. And then providing the feedback. And I'm happy to say that they're improving. I mean, they're not there yet, but they're definitely seeing some very significant progress in each of the areas that they're reporting on. And it was getting that data to the level of the provider that was so important. Okay, impanelment. Why is impanelment so important? Because I'm going to spend a lot more energy taking care of my patients than I am when I have to account for what everybody else does when they see my patient. So high-performing practices are very focused on impanelment. Now, it seems simple, right? There's a group of people. You always see that person. You try to schedule their appointments so that they're always seeing you. Not so easy when there's a lot of chaos in the patient population and there's a lot of emergent need to be seen. So a couple of things you got to think about. How do you handle provider attrition? Know how you're going to handle that ahead of time. So are you going to take all those patients that were assigned to Jane Doe, and when she leaves, move them over to another provider wholesale? And if so, does your system allow you to do that? Most systems don't. So you have to think about how you're going to manage that from the beginning. Secondly, how are panels managed? What does it mean to manage a panel? Am I looking at every diabetic patient? Am I looking at every patient with asthma? How am I managing those panels? Am I looking at every infant or child below the age of 4? How am I doing that, and who's doing that with me?
How do you determine when a patient actually wants to provide it? For instance, we get about half of my patients turnover.
Mm-hmm.
They rent an apartment, they stay a year.
Right.
So when they have rented, all of a sudden there's a panel, they're part of the panel, or
so first thing I would recommend that you do or think about doing, let me ask you this question. Do you know, on average, how many visits a year your patients have with each individual provider? Okay. Is that more than one? Okay. So you right off the bat know that you've got a situation where your patients are going to come see you more than once in that year. Right. Only may see you once. So you've got some constraints, right? So there's a couple of ways to look at that. That you really focus on the 50% that have more longevity, or you say, I'm only going to get to see this patient once. How do I make the biggest bang for my buck? What am I going to do with that patient? And you won't know that until you see it. So you may want to set up your panels so that there's flexibility in that there's always sort of that room for attrition, or always that room for taking new patients in. So I highly recommend the exercise of go ahead and look at the total population of patients, look at it by provider, look at it at visits per year by provider. So that helps you determine the panel size. And you have to determine how many days a year that provider is actually working. So you've got to subtract out vacation, personal days, conference time, whatever it is, and come up with that baseline and know that this is the number of patients that your providers are able to see in a year. And that also helps you determine whether or not you've got enough and how your accessibility is working. So really doing that exercise is critically important to understanding what the constraints are of your particular center. I did that with a group in North Philadelphia recently, and we found that one provider, on average, patients were seeing 5.1 times a year. The overall average at the clinic was around 2.5. So the low end was, 1.5. The high end was 5. So just looking at that number of visits per year that the patient sees you on average across the clinic was really not very useful. And we really needed to look at capacity because they were going to an open access model, and they were petrified that either they would get bombarded and they wouldn't be able to handle the volume, or that people would be sitting around twiddling their thumbs. And it was really useful to go through that exercise of, this is what panel sizes look like. And these are people who are at capacity. These are the people who have a ton of capacity. These are the people who have medium-sized capacity. And how do we fully utilize our team? I hope that answered your question. But you have a constraint. You definitely have a constraint. And that's part of recognizing your constraints is part of making this work. And how are you going to work around that? I talked about determining panel size, and then how do you know when to close a provider to new patients? And again, that's understanding panel size and who has capacity and who doesn't. But we're going to talk about it a little bit more later, but who manages the panel has to be a team approach to be a high-functioning practice. It is impossible to do all of the things, all of the reporting, hit on all of the requirements that a primary care provider has to do without a team around them. So the literature is pretty clear on this, and my experience tells me that it's there. Okay, so team-based care. Obviously, it's things like disease management using approved standards, disease prevention, health promotion, care coordination and navigation, and acute care delivery, and then activities related to transition of care. But again, it has to do with who's doing that. So don't leave anybody out. And I think one area that we don't use enough, and it's actually not on this list, but is pharmacists. How are we using pharmacists that are available to us? I don't think we're using them as well as we maybe should or could be. And I think it's an area that we ought to try working on. But, and don't forget the patient and the patient's family. Mm-hmm. 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 So tell me the kinds of care that they're providing. Tell me the kinds of things that they're doing. Yeah, right. So you've pulled them in to help in that education process. And do you have a sense of what impact that's having? No, I think nurses have a corner on that market. Yeah. Right. I'd really love to. I don't, and I imagine that it's out there, and I just haven't run into it yet. But I'd really love to see some outcomes data on that. I'd love to see the places where that really impacts and what it ultimately does. I think the other area is as a provider, I don't think we use pharmacists nearly enough when we're struggling with a patient in a particular medication regime, and we're just not getting anywhere. We're not moving that patient. Or seeing progress. So ultimately, we're talking about this little tiny triangle here that is where where patient and family, provider, MA teams, and all of the other folks who are, working with patients, and that list could go on and on, could be obviously much longer, come together to create this is the target, this is the sweet spot that we're looking for. Okay, so the ideal model is some kind of phone operator or call center. How many of you are multi-site, multiple sites? Of those multiple sites, how many of you have a call center? Or are you having the phone calls come through? Okay, okay. So, I think this is an area that could probably use to have a little more traction around it, to be using call centers more effectively. Now that we have electronic medical record in place, there's no reason why the patient should feel like they're in any way disconnected if they're calling the call center. They should feel like the person, again, it goes back to that just enough information, just at the right time, in front of just the right person. And they shouldn't feel anything different than them calling your center. But what we want to avoid is the people at the front desk constantly answering the phone and not paying attention to what's right in front of them right there. Then we've got this empowered front desk expanded role. We talk a lot about the medical assistant expanded role, but I would say that this is the front desk, having them answer phones is maybe not the best use of their time, but rather expanding the role of follow-up with patients. So we've done a recall list, and we know that there are 50 kids out there that need to get in there to get their second varicella or whatever it might be, and yet letting the front desk take on that role of getting that communication out and expanding their role. And then we have the shared support team, and again, that list of folks. And then we have this patient and the family working with this clinician MA teamlet. And the concept here is that these folks have such a high level of trust with each other and have worked together for long enough in a stable relationship that they can finish each other's sentences. I mean, this is what your ultimate goal is that those folks really are able to be, especially the MAs, can be a little bit more autonomous than they might have been before. Typically, the way that this works best is to incrementally add roles, not all at once, but rather incrementally improve or increase that role. Provide some decision support at the point of care. So one of the groups that I'm working with, they've expanded the role of the MA to do more risk assessment. So the MA is doing all of the smoking cessation piece, drug and alcohol piece, depression. They've also included a question in there about needing attorney services. So have you, been in a dispute recently or feel like you need some attorney services, and they actually have an attorney on staff who can be referred to, which has been a real interesting place. And also working on things like violence in the home and guns and things like that. And we've expanded the MA role to include all of that. The MAs were pretty uncomfortable about it initially. We did a lot of role play, but we also embedded some clinical decision support in the form that they use in the electronic medical record system. So it required a little bit of customization, but it's paying off because now we're getting that information more standardly or more often, it's easier to get, and also we're able to do more internal referrals. So if the patient has a BMI, for example, of greater than 24.9, they can refer to the behavioral health coordinator, the BHC who's embedded in their site, or to the nutritionist. And we've empowered the MAs to go ahead and make those referrals. And it's interesting because many of the MAs come from the community. They're very well trusted by the members of the community who are using them. If you're recommending it, then I can make it work. So that's been really interesting. So what we did was, before we put that form in place, we required operational training. That's where the role play took place. And then once that role play took place and we trained them on workflow and how that was going to work, then we taught them how to use the form. We didn't try to teach them how to use the form out of the context of how it was going to work operationally. And that's how we've had some success. Okay. So the other area that I want to talk about a little bit is creating expectations up front for the use of the EMR and other things by your providers, and also creating standing orders. That's how you're going to be able to really help the MAs to have a little bit more autonomy. I think you'll also find that you'll have less turnover in that role if they are more autonomous, because often they know exactly what needs to be done, but they're not empowered to do what needs to be done. So getting them there is really, really good. So the stable team. This is a tough one. Consider allowing them to self-select. Now this gets to be a little bit dicey. And I will say to you, don't put the most disorganized provider with the most disorganized MA. You know, you want a little yin and yang here. And if this is a provider that still has 1 million documents stacked up on the desktop of their EMR, they probably had 1 million charts stacked up on the floor of their desk of their office when you were on paper. That doesn't change when you go electronic. In fact, it probably gets worse. So you want to put two people together who have complementary skills and not necessarily going to allow each other to, you want them to make each other better, is my point. One of the things that I think has been tough, and I've worked with a couple of groups on this, is there are providers that nobody wants to work with. There are MAs that nobody wants to work with. And that's the dirty little secret that we all have. Every one of us has that provider in our mind. It's like, if I never work with them again, it will be too soon. But on the other hand, to mix my metaphors, every pot has a lid too. And what I've found is that when we empower the MAs, when we expect more of them, and when we set expectations, sometimes we can get around that stuff. Sometimes you can't, and it is what it is. But that's a tough area. And a lot of groups don't assign an MA to a provider because they're trying to avoid exactly that problem. So what I try to do is I try to get leadership to land on the things that are non-negotiable. The pieces of the use of the electronic medical record, the pieces of the workflow that are non-negotiable. And so have rules, but don't have 1 million rules, so that you can allow for some latitude among those teams to do what's comfortable for them. But to create some expectations up front that these are the things you have to do. So you have to produce a clinical visit summary, for example, which means that before the patient leaves, these are the 4 components of the electronic medical record that must be complete. Now, how you finish the rest of it, you've got, your 24 to 48 hours to get that thing signed. I don't care. But these are the pieces that have to be complete so that that clinical visit summary has at least these things on it. It's things like that, creating that level of structure and that level of expectation, as opposed to the hard and fast, you must. So, I told you I've been a nurse since the earth cooled, and I cut my teeth in a neonatal intensive care unit back in the 80s. And at the time, we all had to wear scrubs and white stockings and white shoes. I worked night shift. So guess what? It was like, you're lucky I'm here. It's the middle of the night, okay? And we prided ourselves in the crazy socks that we wore. And we all tried to wear the crazier socks, the better. And I remember very distinctly the clinical director coming in and cracking down on us and said, the dress code is white stockings, white shoes. You have to do it. Okay, we all did it, and we put the craziest shoelaces we could find in our shoes. So it's human nature to want to exercise our creativity muscle a little bit. So I recommend having rules, but allowing some latitude in those rules so that people can function. And that's how you'll get people to gel as a team, by allowing them to have some leeway and to be able to work with each other so that you're meeting the requirements, but you're meeting it in your way. So, so here's another area. Try to work with providers to change their mindset from a simple delegation of responsibility to an accountability. So, example, I want you to run a report. Now, this is all that you can run these reports at the desktop, right? But I want you to run a report on all patients who have the ICD-9 code of diabetes and have not had a hemoglobin A1C in the last 90 days. And I want you to invite all those patients back in. And then a month later, we run that report and we don't see any improvement there. That's the MA who's not getting, that's part of their responsibility to get those patients in. So it isn't about being pejorative and, dinging them for that, but rather saying, how did you approach it? How do you think you could have approached it differently? Should we consider a different approach? And again, empowering them. So it's not just simple delegation, but more of creating responsibility and accountability at that MA level. And then this often works to do a little therapy and allow the MAs and providers to talk about, just like that young woman said to me, I don't trust my MA. And when she said that, that's so telling. And as if I were the medical director who was sitting right next to her at the time, that's a teachable moment. That's a moment to seize on and say, what are we going to do about that? There's a solution there. And I happen to know these MAs. Like, I've worked with these MAs. And these are perfectly capable women. I don't think they have any men working as MAs in that group. But they're perfectly capable people. They're smart. They are hardworking. They are up for a challenge. They're very committed to their community. It's a primarily Spanish-speaking community, and all of them must be bilingual to work there. So these are smart people. There's no way that they can't do what they're being asked to do. It's just a matter of getting the providers to let go a little bit. Okay. Principles. Encourage all team members to work and define what is most important to them. And again, this is where you create some leeway. And as long as what they're thinking about is congruent with the overall mission of the organization, I don't care if you go over hill and dale to get there, as long as you're getting there. And if the way that you need to get there is your way, then that's fine, because I'm really interested in the outcome, not so much interested in how you're getting there, except for what do I need to do to smooth that path out for you from a leadership position. So the goal is that each team member has a sense of purpose that is aligned with the organizational mission, and you get them to verbalize that. So that time is really can be really well spent. Now here comes one of my favorite areas, workflow. I don't know how many of you, I know the Epic people did this, but I don't know how many of you sat down and mapped out the workflow of how you were going to do each process using electronic medical record before you put that electronic medical record in place. But it is the single most important thing that you can do, and it has the greatest yield. It's a ton of work. It's annoying because you have to deal with every little I that you dot and every T that you cross in that mapping out that process. It's painful often and takes a ton of time, but it has got so much benefit on the other side. So a lot of work can be done to really map workflows, and they can define your training needs. They can provide context when you're teaching people how to use the electronic medical record, and quite frankly, it sticks better when you're teaching people how to use something in the context of how they're going to actually do it, and not just when you want to e-prescribe, go push this button and that button and the other button, but rather you're going to e-prescribe at this point in the visit, and this is how you're going to navigate from here to there, and that's how it sticks much, much better. So working on workflow, and then you limit the amount of supervision that's required, because you map the workflows, you redesign the workflows to best fit the functionality of the system, and get your work done at the same time. You then work with people for the next 28 to 30 days to create that habit, and then you can forget about it, and it's gonna almost create an autopilot, and you don't have to spend so much time standing over people and making them do things, but rather really working on the things that matter. Like how are you listening to your patients and improving the way that you can do it. And then once it's documented, you can easily evolve it with the practice. So here's an example of a workflow map. I don't expect you to take all of this in, but you can see why I say it's very, very detailed. This one happens to be a workflow map that is doing orders reconciliation. So doing orders and results reconciliation. So this is that big accordion file that we used to have in the paper world, where we would file the lab slip and the date that we expected it to come back and look for it. This is the workflow that deals with that in the electronic world. So it can be, a little bit more involved. But what we often will do then is take this, and that becomes the procedure for the policy that you create. So you write the policy, and this is when you do it, and this is how you do it, and then you have this workflow map that really spells out what needs to be done in each of the steps. Okay, I know this communication, again, we've talked about this for a long, long time. But I do recommend huddling. How many of you are doing huddles? How effective are you finding them? Right. So it sounds like yours are interdisciplinary. Everybody goes. So the point, go ahead. No, I'd like to hear more. Excellent. And are you putting pending orders in at the point of the huddle? So before the patient ever gets there, you're teeing things up so that it's really a matter of completing them once the provider's in the room. And when you're hearing providers complain that they can't get everything done, that they have to do 10 times more than what they do before they had the electronic medical record, it's because there aren't enough people putting that information in. It cannot only be the provider. It has to be more than the provider. Mm-hmm. Right. So you bring up a really good point. There is a tendency to put all the providers in one big office and have them all working together, and put all the medical assistants or LPNs in another office where they're all working together. And there the twain shall meet. And it doesn't work. It's not very effective. It's very isolating, and it doesn't create that team approach, nor does it really foster the kind of autonomy that you'd like to foster because it's very empowering to sit beside the provider and have that and get taught and learn more, and then be able to do a little bit more and get taught more and do a little bit more. It's very useful. I recommend huddles at the beginning, huddles in the middle of the day, and if you can, one at the wrap up. So you guys are ahead of the game where you have 2, and ideally, I think 3 would really, really help, because then you're preparing yourself for the next day, which will make the huddle the next morning that much more effective. I mean, there are ways to, because what happens is the more you do this, the lower the workload gets each time you do it. Open access. How many of you are using open access or advanced access? How challenging is that from a huddle perspective? So can you talk a little bit about how you manage that? Like at what point in the day is your schedule full, and how much of your schedule is open to? Okay. 40%, 60%, or does it vary? Okay. And do you have particular types of patients that you always pre-schedule, like your children who need, who are having well child visits regularly or anything like that? And what's your no-show rate like? So it takes constant modification, doesn't it? It's not a once and done kind of thing. It really does. Yeah, it's very dynamic. Anybody else using open access? So I was working with one group where one of the real challenges around open access was that their schedules would get full by 8:30. They opened their phones at 8. By 8:30, schedules were full. They had almost 100% open access. And the problem with that was that new patients were having a very difficult time getting in because by the time they would call, there might not be another appointment available to them, and there was nothing to guarantee tomorrow that they would also have time. So that became very, very, very challenging, and ultimately moved to more of a advanced access kind of model where they kept some appointments open so that they could get their new patients in. And
so I think it's harsh, but
mm-hmm. Mm-hmm. Right. Mm-hmm. That was getting to be a big problem with the community board. They were getting a lot of real negative feedback from their community board around us. So again, there's no right or wrong answer to this, but rather it's the kind of thing that you just need to keep your eye on. And I recommend that you work with the scheduled appointments first in your huddle and then move on and hopefully get your schedule as full as possible when you can. And then letting the full teams meet monthly or more often if it's possible, especially if there's special initiatives underway. But getting those full teams to meet monthly. But it sounds like a lot of you who are using the huddle are getting that to be interdisciplinary right off the bat. So that's a great thing. We talked about standing orders and facilitating team autonomy. So just when you are feeling like you have a capacity issue, I highly recommend you look at your patient flow because you can improve. So I was working with a group, for example, that it was taking an hour and a half for every well child visit because of the bottleneck of immunization delivery. So that was an area that we had to focus on because their capacity was actually greatly reduced by the bottlenecking that was happening within their group. So that's a place that you can build capacity. So here are some helpful tools, things that have helped me, things that have worked for me and the groups that I've worked with, is incrementally expanding that role of the MA. We're probably going to do a pharmacology course for medical assistants that is going to be very, very, very basic, but at least give them exposure to the names of medications and particularly the difference between generic and brand name, which seems to be a big confusing factor. So we're looking to do that with this group where we're expanding the MA role. Use the EMR to facilitate the huddles. How many of you are able to print out a before visit summary or have thought about using a before visit summary? You guys are using that? So, pardon me? Yeah. What system are you guys using? Okay. Yeah. So using that before visit summary, so this is information that would populate an after visit summary, but it's the information that you already have in the system. You can use it to kind of really monitor your huddles or use it to facilitate your huddles, but more importantly, print it out and give it to the patient or have the patient view it in some way. We're actually thinking in one group that we could maybe get, I don't know if you're familiar with Freesia. Anybody familiar with Freesia? it's basically a mobile kiosk kind of deal. But so we'd be able to give the patient a view of their before visit summary, and we're asking them, tell us what's missing, what's maybe wrong, how can we fix that ahead of time, and making that a part of the MA intake to review that before visit summary with the patient to correct any information that might be in the EHR wrong. But so consider how you might be able to use that EMR. So every one of them will print an after visit summary, right? So they have to. But what my recommendation is to look at what's on that after visit summary and think about what customization or modification you might need to do to make that before visit summary a little bit more useful from a Huddle perspective. So there are various pieces of software. Anybody familiar with I2I software? I2I is an overlay on top of the EMR, and it actually allows for a Huddle summary. It's canned in their system. So that can be very, very effective using that. And that's what I mean about care management software that might enhance the functionality of your EHR. The sad but true fact is these EHRs will not do everything that maybe you want them to do. Or if they do it, they don't do it as well as you need them to do it. And that's just kind of a reality of where we are with software. I would say maximize the use of the summary screen that's in every EHR. Every EHR has some kind of an overview of the patient. And it depends on which one you have, how flexible that is. But using that summary screen can often be just the thing that you need to facilitate the huddles. And can, in some cases, so for example, in Centricity, right from the summary screen of the patient, you can get to orders, you can get to medications, so you can actually manipulate the patient data very quickly, very easily, right from that summary screen. So enlist the help of the MA to manage panels through better use of the EMR, and this is run reconciliation reports. Is everybody using computerized provider order entry for everything? Are your providers putting all their orders in the system? Yes, no, mostly? Okay. So that allows you to do that reconciliation. If they're not putting the orders in, it's impossible to do the reconciliation. But I think we abandoned that, or in some cases abandoned it when we moved from paper to electronic. We used to do that reconciliation all the time. Look for the results that didn't come back. We used to do a chart prep on a regular basis, get the paper charts ready for the next time the patient was seen. We don't necessarily do that as much in the EMR for some reason. And it can be very, very useful. Running those chronic disease reports that we talked about, running a weekly immunization report. I'm in the middle of doing an audit right now on immunizations, and I know the providers would be shocked at the number of missed opportunities to immunize kids who were behind on their immunizations. I know they would be shocked. I know they don't think they do it, but they miss opportunities over and over and over again. And the way to do it is to run that weekly immunization report so that you know who should be getting their immunizations. Same thing for cancer screens, and then really adopt a process to contact and invite your patients in. And there is software out there that will actually go through your system and farm it and invite patients in automatically. I think most of us think that that's more money than we want to spend necessarily on software, but it can really improve the utilization of your providers. So I wanted to pause here and just throw out some of the points of discussion that I've run into in the past, open it up to any questions. And again, as I said, the value here is hearing how the rest of you are using these kinds of methodologies or concepts, and where you think you might struggle or you might have some hard sells on some of it. So I wanted to throw it open to the group, and I threw a few things up there that that particularly impacted when I've worked with groups. Anybody? Any questions? areas that you'd like to further explore? Caught you after lunch? Better than after the happy hour. Okay. So, in terms of I'm working with a physician right now who's really working on this expanded MA role. And one of the things she said is she spent a lot of time training, educating the medical assistants, bringing them up to speed, and what she really found out is she needed to spend more time with the providers because they were the ones who were struggling to let go. And they were the ones who were delegating, but they weren't creating a real, true accountability kind of model. That they were just telling the MA what to do instead of creating that autonomous, we're in this together, we're going to manage this panel together, we one for all for one kind of mentality. And I worked with another group where we were trying to make some changes in the EMR. And these were changes that were really, really needed, and they were working on old, outdated content, and it was really cumbersome and difficult. And her attitude, I know she didn't mean it this way, but she just kept saying, it's really going to be awful, this change. That was the message she kept giving. So guess what? It was really awful, So, just trying to turn that mindset around. So we put in place a real process for after we did this change, and then we created an after go live regular phone call. And at one point, the woman who was the application manager for the EMR said, "So is anybody struggling? Anybody having any problems?" It was just dead silence. So the leader stepped in and said, "They're just all shell-shocked." And the application manager said, actually, I take that silence as things are actually going pretty well. So it was just reframing it, and she was actually right about that. Uh-huh. Mm-hmm.
So we looked at what kind of changes patient satisfaction to,
right,
clinical indicators to,
right,
and provider productivity to. So we're trying to say, what did you do that kind of like this whole shift? Is there some kind of improvement?
So I think the area that most folks look at, or most folks are working on, is referral management as part of patient-centered medical homes. Is that an area that you guys had to address, or was it in pretty good shape when you? Mm-hmm. Well, you might not realize how lucky you are, because that is not, at least in the experience, and maybe I'm just seeing the worst of the worst. I don't know, because of the business that I'm in. But the honest truth is we are struggling with that in many, many cases. So you all know you've got to report on UDS, right? On what's you've got to report on birth weight, and APGAR scores, and all that fun stuff. We have situations, and they will remain nameless, but we have situations where entire delivery room lists are just passed on to the centers. Pick the ones off of here that are yours. That's what we're dealing with not a lot of integration. So you may not realize how lucky you are. So maybe you just got, kind of validated that it can work, but it does require intentionality on part of the health systems that are working around the health centers, as well as the health centers being very clear what they need. So so just educating them on what is a CCD document and how your system can handle that and how we can get that directly imported has been a lot of the area that we're working. No, they wouldn't have been. They absolutely wouldn't. In fact, they might have been impossible. And that's what many groups are up against. It's kind of impossible. And also thinking about how you're going to measure success going in. So that's, to your point, what's success going to look like for us? How's that really going to look? So I often try to get groups to think about what are the formative evaluation things that we want to be looking at along the way, and not just get to the end and say this was a success or it wasn't a success, but rather how are we getting there along the way. So in case you didn't hear me, I'm doing the typical teacher thing, which is to reiterate it, that you cannot do it alone as primary care provider. You've got to have a team around you. That successful, high-performing medical practices have effectively implemented team care, and that they are transitioning to this new model through clear articulation of the vision for transformation, fostering strong clinical leadership in each teamlet. So instead of thinking about this big medical director, let each provider almost be their a little mini medical director under the overall, as long as it's fitting into the overall mission of the organization and that they're clear on what the goals are. And then encouraging mastery and support the care teams to purposeful progress and really look at what does that progress look like. So I'm good on time. So any questions that you might have or any ways that you think I might be helpful to you guys as you're, but it sounds like a lot of you have got it under control. I don't know. Having a little bit of trouble reading this group.